you will help us redefine the first-line treatment.
Thank you, Rolf. Always a pleasure to be here, and thanks to Giannis, who quite literally brought the house down with relapsed small cell lung cancer. But we'll now talk about frontline treatment. And so my name's Stephen Liu from Georgetown University. Thanks to everyone for being here with us today. These are my disclosures. As we've just heard, a lot of promising agents in relapsed small cell lung cancer with impressive response rates, and I think the potential for durability, which is something that has eluded us for many years. I think the entire story in the past few years has been focused on relapsed refractory small cell lung cancer, but we really need to pay attention to the frontline setting. Giannis has captured, I think, very well the palpable excitement in the second-line setting, but we really need to pay attention to initial therapy in small cell lung cancer. And as exciting and promising as these relapse agents are, their impact really is limited by attrition. And if we want to help our patient expand that impact, we need to move these drugs up earlier. For patients that receive any treatment in the frontline setting, only half receive any second-line therapy, only a quarter receive any third-line therapy. These numbers have been remarkably consistent and, if anything, are conservative. And it's because this remains a very unforgiving disease. When patients relapse, they often don't survive that relapse or are no longer candidates for sometimes our best therapies. And so if we want to impact survival for small cell lung cancer, we need to do that in the frontline setting. So how do we integrate some of these drugs we've heard about earlier? Can we extend that benefit to more patients by ensuring they receive in the frontline treatment? And biologically, is this a better place for these drugs? Would their efficacy be even better before relapse in a more sensitive disease? Put another way, I think the overarching question we have going forward in the next few years, what is the optimal first-line treatment for extensive stage small cell lung cancer? Let's look at our current standards. It's now been 7 to 8 years since we saw 2 phase 3 trials redefine the frontline standard. The Empower 133 trial and the Caspian study showed that adding a PD-L1 inhibitor to standard platinum etoposide offered a modest but significant improvement in both progression-free survival and overall survival, with hazard ratios of 0.7 to 0.73. I'll start with the first question. I do not see any meaningful difference between these two drugs. Right? In fact, multiple randomized trials have shown very similar findings, that when we add a PD-1 or a PD-L1 inhibitor to first-line chemotherapy, we have a fairly consistent improvement in survival despite subtle differences in epitopes, in study population, and trial design. What we're seeing are steady improvements in survival and improvements in landmark survival. This translates to the real world. Our own Charo Campello showed the IMfirst data, a phase 3B study of platinum etoposide atezolizumab in Spain, including patients that were excluded from phase 3 trials, also showing very similar landmark survival rates, and we know these can be durable. 3-year survival rates of 18% in Caspian and Umbrella and Empower 133, 5-year survival rates of 12%. Numbers that certainly are not as high as we want, but also very clearly better than what we had. What we have today when we see someone in the clinic next week with extensive stage small cell lung cancer is something we haven't had for many years, and that's hope. Hope for a long-term survival, about 10 to 15% of patients achieving meaningful, durable response. This is our standard of care. And we can accept this and be happy for this, celebrate it, and yet also acknowledge that it's not good enough, that most of our patients will relapse and will need other therapies. And we also know that if we wait until relapse, most of those patients will not be afforded that opportunity. And so we need to continue to improve treatment. At this last ASCO, Luis presented the IMforte study, a phase 3 trial looking at maintenance lurbinectedin, proactively adding lurbinectedin at the time of maintenance therapy before progression. And what we saw was an improvement in PFS, I think a striking one, of the PFS hazard ratio of 0.54, and that did translate to an improvement in survival, with an OS hazard ratio of 0.73. And if that number sounds familiar, 0.73 was the survival hazard ratio for Caspian, and as we'll hear soon, for Adriatic, a meaningful improvement in survival with the early introduction of lurbinectedin. Certainly we had toxicity, fatigue, anemia, myelosuppression, and while tolerability and manageable toxicities are subjective terms, I'll note objectively that the rate of stopping any treatment for toxicity was only 6%. And we saw a few months ago at the North America meeting that did not impact functioning on PROs and quality of life data. Important aspects to remember when we're adding more therapies. We're extending survival without impacting the quality of life of our patients. What about radiation? This is a radiosensitive disease. Prophylactic cranial radiation based on the EORTC studies showed that giving PCI decreased the risk of brain mets, improved survival, but this was pre-MRI. And if we recapitulate that study in the MRI era, we saw that currently PCI does reduce the risk of brain mets, but that did not translate to a difference in survival. And if you look at the bottom right there, while you do see these curves separate a bit, remember that blue was observation, blue was surveillance, and that hazard ratio of 1.27 is on the wrong side of 1. We have ongoing phase 3 studies to really redefine our standards. The Primal Lung study by EORTC, the Maverick study by SWOG in the US will give us clear guidance on this. But as we know, the use of PCI has dramatically decreased in recent years. What about thoracic radiation? The CREST trial, a negative study that did not meet its primary endpoint but did show some numeric improvement. This comes from an era where our bar for success was quite a bit lower, and certainly before immunotherapy. The ongoing phase 3 RAPTOR trial will define the role of thoracic radiation. Is this additive? Is this synergistic? Or is this potentially antagonistic? We'll have an answer hopefully soon enough. But moving on to newer systemic agents, how do we integrate bispecific T-cell engagers, bispecific antibodies, and antibody-drug conjugates? Tarlatamab really has taken the world by storm, and we see some very encouraging data with tarlatamab as a maintenance agent. This is potentially a better place for this. When we think of how T-cell engagers work, what we would expect is these drugs would be more effective in a state of a lower burden disease, where you have a more favorable ratio of effector to target. And so if there's less disease, you have more opportunity to engage T-cells one-to-one. The Delphi 303 study, a multi-cohort trial, looked at maintenance tarlatamab. And what we saw there was a median PFS in the maintenance setting of 5.6 months. Not that different from what we saw in lurbinectedin, but we did see quite a striking survival. The one-year survival rate of 82%, quite a bit higher than we've seen with other studies, and that was with atezolizumab or durvalumab. Very impressive one-year survival rates. Now, we all know that there's incredible selection bias with these studies, that when we see patients in our trials, in our clinic, to put someone on a T-cell engager trial in the frontline setting, we are really looking for the best of the best. This is not our typical general population, but it's hard not to be impressed by these survival numbers. And what about in the frontline setting? Another cohort in Delphi 303 that Martin Wermke presented, 1 cycle of platinum etoposide immunotherapy, and then adding tarlatamab to the last 3 cycles of induction and continuing it as maintenance. And again, the PFS here, I think quite impressive at 10.3 months, and that one-year survival rate, again, 80%. We need these to mature. We need to see bigger numbers. These are impressive. CRS and ICANS remain unique toxicities, but as we've seen in later line studies, these generally tend to be front-loaded. And seeing these toxicities once you get past cycle 1 is pretty uncommon, and I think we as a community have gained more comfort anticipating and dealing with CRS and ICANS, those still important toxicities, especially as we implement these treatments in larger settings. And so we have some ongoing studies. Delphi 305 has now completed accrual. This is maintenance tarlatamab plus durvalumab, a 560-patient study. Delphi 312 looks at adding tarlatamab in the frontline setting. This is recruiting now. And Darien Lung 1 looking at platinum etoposide atezolizumab and obrixtamig. Other studies in design or in talks. What would we gain from adding tarlatamab? And I think the real question is, will we see those first-line outcomes exceed that with second line? Is this a better place for T-cell engagers? And will early introduction recapitulate those very impressive long-term survival rates? Is this how we're going to maybe cure more patients, or at least let people see more years? And I think all of us feel this is going to be the case, but there are details. Is there anything we could lose? As we look to interpret these studies, how do we address selection bias in these trials? Are these going to be representative of all of our patients? We will not currently treat all of our patients with tarlatamab based on performance status, comorbidities, and a lot of other factors. How do we capture that in analyzing these studies? Is this approach optimal for every patient that walks in the door? Can we do a better job predicting toxicity? And of course, as we heard from Dr. Veronesi yesterday, what is the economic impact of starting a T-cell engager early on and continuing it every 2 weeks for the rest of their life, especially if that life is going to be much longer? Is this something we need to give forever, we should give forever? And how do we really account for delivery of this on a global scale? But these are good problems to discuss. What about bispecific antibodies? We've seen some very encouraging data with several compounds, pumitamig, a PD-L1 VEGF-A bispecific antibody. We looked at it in the frontline setting. John Haymock presented these data a few months ago at WCLC. What we saw were fairly high response rates in the frontline setting, 85% of that 20 mg per kg dose, 100% disease control rate, and PFS numbers that look encouraging, around 6-7 months, but not blowing anyone away. We also saw with ivonescimab in the frontline setting with carboplatin etoposide, response rates high, 80% encouraging, solid PFS and OS numbers. What we need here, though, are randomized data. And I guess the question is targeting VEGF here going to improve survival? Will our cooperative binding allow more immune-mediated responses? Will we see better long-term survival by more properly engaging PD-L1? Only time will tell. But what could we lose? Will this come at a cost? Will more adverse events impact delivery? We want something to help immunotherapy, but it's also very important that we not get in the way. We don't want to gamble with that 10 to 15% 5-year survival rate. We certainly don't want to lose that. And then antibody-drug conjugates. These are very impressive numbers, high response rates in that previously treated setting. It's hard not to be impressed by some of these early data from ADCs. And we do have some ongoing studies. Delphi 310 is going to look at frontline YL201 with PD-L1 and tarlatamab, other combinations in development, and will we finally see the era of platinum etoposide come to a close? This is a combination that was introduced in the 1980s. Is it time to move on? Do we now no longer have to bring people in for 3 days? Can we have a one-day regimen, and are these better partners? Those response rates in the frontline setting, will they be even greater? And we'll start by saying platinum etoposide already has a very impressive response rate. It's hard to get much higher than that. I think a better question is, will deeper responses improve outcomes? And the depth of response may more favorably improve that ratio of effector to target. This could really be important when we think of how T-cell engagers work. And so the ADCs may be better partners, may be synergistic with the mechanism of action for T-cell engagers. But what could we lose? What do we leave behind? And while it's easy to take platinum etoposide for granted, there are a couple important factors in that regimen. Is platinum etoposide helping some patients that ADCs would leave behind? And I think an important aspect that hasn't been properly studied is, will we have the same initial CNS responses and control? All of us are comfortable giving platinum etoposide to someone with asymptomatic, untreated brain metastases. Would we see the same effect with ADCs? And will toxicities again impact the delivery of combination regimens? Will we have to hold therapy or stop therapy due to ADC toxicity that would then prevent us from giving a T-cell engager or immunotherapy? It's very important that we not sacrifice what we already have. An important reminder when we look at small cell data is that short-term gains do not outweigh long-term benefit. And while we get excited by waterfall plots and response rates north of 80%, we've been fooled before, and response rates and PFS, these are fool's gold. Really, survival is our ultimate arbiter of success, and we've seen responses in small cell lung cancer for decades, and very rarely did that translate to concrete gains in survival. We really need to watch long-term survival with these new regimens. And this is a very difficult disease to study and treat. And all of us have been very excited, and many of us have led exciting phase 3 trials based on promising phase 2 results that have shown no improvement. Cisplatin irinotecan, right? Very impressive survival benefit, 0.60, 2 follow-up trials that showed no difference in survival. Martin showed us with ipilimumab, tantalizing phase 2 data with a PFS hazard ratio of 0.64 with IPI, a nice trend for OS, and the phase 3, no benefit in PFS, no OS benefit. Remember, these earlier phase trials are at select experienced centers and staff, very strict eligibility, and a lot of selection for better biology. These are patients that have the resources to travel to a research facility, that have a lot of support, and we are probably selecting for a different type of small cell. When we open it up to a phase 3 trial, it's a more real-world population, broader eligibility criteria to do a 500, 600 patient study, more generalized and heterogeneous biology as a result, and this is very often why we have a promising, solid phase 2 that has no impact at phase 3. So when we come back to the overarching question, what is the optimal first-line treatment for small cell lung cancer? We don't have an answer yet, but I don't think this is the right question. The right question is, what is the first-line treatment for my patient with extensive stage small cell lung cancer? And empiric therapies are going to be less transformative. We do need biomarkers to guide treatment. Empiric strategies give incremental benefit. If we want transformative, it needs to be personalized, individualized, and really needs to reflect the heterogeneity of this disease. In addition, small cell lung cancer is changing. Transformed small cell remains a therapeutic challenge, and I suspect we'll see more of this. As our frontline strategies improve, as our target agents become stronger, we're going to see more lineage plasticity. Tissue biopsy is still critical in understanding that. And applying what we know in small cell de novo to transform small cell is not very satisfying. This clearly is a different disease. I think this is well illustrated by a recent series of tarlatamab in EGFR mutant transformed small cell lung cancer, where only 1 in 14 had a response. And the median treatment duration, only 1.5 months. And this has been our experience too. Very disappointing. We were excited here. We are much less so now. Small cell is changing. If we look at our randomized phase 3 trials of immunotherapy, the earlier trials had less than 10% of patients with no smoking history, but now we're at about 20% of patients with no smoking history. And our suspicion was that these were transformed, but they are not. And we're now seeing this migrate over to the West, where it's not uncommon for me to see patients with no smoking history to suspect a de novo transformation, but on NGS seeing no EGFR mutations. This disease is changing. And when we look at those never smokers that develop small cell lung cancer, while some of them do have that P53RB typical genomic signature, there's an atypical form where TB53 and RB1 are intact, where we really see chromothripsis of chromosome 11 and 12 and extra chromosome amplification. It's a different biology, and we need to treat it differently too. So we want to leave some room for hope. Our frontline standards, chemoimmunotherapy, achieving long-term survival, maintenance lurbinectin, improved survival. We will see changes in the near future. Tarlatamab and other T-cell engagers almost certainly going to do it. I think we're very excited about the T-cell engagers. I think we're optimistic about ADCs. And I think we're hopeful about bispecifics. But to really move forward, we need biomarkers to optimize delivery. And so I want to thank everybody for being here for one of my favorite meetings, for everyone coming together. Thanks for your time.